presentation. I want to introduce to you our guest speaker, Dr. Desai. He is an he's board certified psychiatry by the board, American Board of Psychiatry and Neurology, and a fellow of the American Psychiatric Association. He has numerous published peer-reviewed publications and has taught at the University of Maryland School of Medicine, the St. Louis School of Medicine. He's also been involved in Alzheimer's disease pharmaceutical research. Some of Dr. Desai's key achievements are co-founding with his wife the Idaho Memory and Aging Center and publishing a book, Consultations in Long-Term Care, a guide for health care professionals, and being nominated for both Distinguished Teacher Award at St. Louis University School of Medicine, the Caring Physician Award in 2009 from St. Louis University Hospital. Dr. Desai enjoys hanging out with his wife and son, traveling, reading, hiking, playing tennis, and table tennis. Please welcome Dr. Desai.
Hello, delighted and honored to be here. In my pediatric psychiatry practice, a lot of patients come with depression, but actually the primary problem is pain management. A lot of patients actually come with memory problems, and the primary cause of memory problems is actually the medications we give for pain management. And in the last 10 years, we've really seen the capacity the brain has to change if we change the person's experience. So one can train the brain to think differently and experience differently, and that one can harness to manage pain much better than what we have been doing so far. So although it says last 10 minutes for Q&A, I'm hoping to stop earlier so that we can have a dialogue. So without further ado, no financial relationships. I'm not many speakers, bureau, or any pharmaceutical company. So we'll talk a little bit about neuroplasticity, and I'll make a case of why opioids really we need to use much less than what we are using, but what to replace it with. So what is neuroplasticity? I have a patient currently in the inpatient unit. She's 83. She has severe pain that she's had for several years. She's on very high doses of opioids, and she was misusing them. Not using it to get high. She was just using it not appropriately. She didn't have any cognitive impairment. And so the primary care physician and the pain management physician decided that enough, we're not going to prescribe it to you. So she was hospitalized to manage withdrawal. And again, when she said, so which other medicine are you going to give me? A lot of the first 5-6 days was spent in explaining to her that if we change our reaction to the pain in certain ways, then maybe your pain will be less. The effect won't be as good as opioids, but the risks will be much less, and you might still be able to function well. She underwent very severe withdrawal symptoms, and we treated that. And then she really started taking part in sort of stretching, muscle strengthening. We have an occupational therapy assistant over there who was involved in that. She actually was willing to engage in visualization. She wasn't interested in quote medication. She felt it was sort of religious, but she was open to doing the same thing, but we would call it breath awareness exercises. So she was fine with that. And then, she had a good sense of humor, so we sort of focused on that and tried to crank it up. We used lidoderm patches, we used Lyrica. She had neuropathic pain too. And things really turned around to the point where she was discharged without opioids. Now we'll see how well she does. That's a whole separate story. But we also involved her friends. she didn't have any family. But the key thing is to enhance neuroplasticity. You know, if you just involve the person without their support system, the effect may not be as good because our brain is very responsive to sort of social settings. So, so one of the things that I was trying to convince her is that each time she would have pain, her brain was wired to think of, I need more pills, or which pill should I take? So, and if you do that like 400 times or 4,000 times, then the cells that fire together, so these two cells are firing together, are wired. So now I cannot expect her to suddenly not do that for the next 10 days or 10 weeks, because those two cells are going to fire together and wire together. So each time she thinks of pain, she is going to think of medicines. But again, these brain networks are like plants. So if you give them attention, it's like pouring water, so you make it stronger. And if you don't give them attention, then sooner or later they become weaker and they die off. So I was trying to get her to think that each time you think of pain, you see it as a message from the body that you need to do something. And do something could be, then we have a list of physical activity, meditation, relaxation. And also cells that fire apart, wire apart. So when she would have fun, she associated that with, after taking her medication, she was able to concentrate and enjoy a TV show and things like that. So we had to, again, I had to talk to her and tell her that even if you are in pain, you'll be able to enjoy, say, a TV show. And in fact, if you watch comedies and avoid watching any news, then I'm serious. Then the laughter will release the same chemicals that a lot of the medications will release, and then you will see a difference. So again, we need to, because a lot of times they say that living with pain is actually no living. So we need to help them realize that there are a lot of gray zones, there are a lot of sort of short spots between moments when the pain is less, and one can use that to do some things differently. And again, a lot of this is brain training. So if she would get frustrated that nothing has happened. And I would say that you've just started it. It'll take time. So let's just keep at it. And so you have to sort of train your brain. And there's no reason to have, many times you don't have to undergo cognitive behavior therapy, although that is an excellent approach to a lot of patients who are in chronic pain. But if you just focus on behaviors, there is a good chance that the brain will change anyway. Again, I was trying to tell her that it's impossible to be tense and relax at the same time. So when you're tense, different parts of your brain networks are getting activated. Say the amygdala, the place where there is fear. And if you're relaxed, different parts of the brain are getting activated. So again, and when you're tense, then the muscle will contract, and then there's a good chance your pain will go up. Also, when you're tense, certain brain transmitters go up, and when they go up, they just increase the volume in the brain. You think the pain over here is increased, but actually the volume in the brain was increased. Now, all this is especially true for chronic persistent pain, where the main problem is in the brain, not in the actual part that was injured. And again, lot of approach focuses on distraction. So if your mind is somewhere else, if your mind is engaged, especially in something that you're really interested in, then there is a good chance that you're not giving attention to the pain experience. And just by not giving attention, you're taking away the water that otherwise you would be feeding to that brain network. So people who have a lot of empty spaces in their days, that's a trouble for more pain and then more medications. And again, when you activate one network, it's going to shut down, at least temporarily. If you're laughing, it's going to shut down. If you're, say, doing breathing exercises, if you're walking and you're focusing on walking, not focusing on pain, right? So you can walk but focus on pain, or you can walk and focus on, people coming in and out of the room, or the parking lot, or the nature. But if you're not focusing, then again that should help. So we need to realize that chronic pain is actually a neurological problem, not problem in, say, the joints or the low back pain, because there has been, the whole network has been rewired. This is no different than addiction, where the whole networks are totally rewired. And that has plus and minuses. The plus is that then a lot of this brain training can really alter these networks. The minus is that if you don't realize that and focus on medications are not going to alter the brain networks in a positive way. They will just shut down certain neurotransmitters. And actually, in the long run, they will alter brain networks, brain pathways in a negative manner, especially opioids. There are a lot of reports that some subgroup of patients on chronic opioids develop pain because of taking opioids, because the whole brain network has been rewired. So we need to realize that, it's the rewiring of maps. And also a lot of these nerve fibers go together. So when they're rewiring, the things that, should not cause pain, like touch, they will get cross-wired with the pain, with the brain cells that fire for pain. And so suddenly you experience now a very different kind of pain, which is from non-painful stimuli. So again, that's rewiring. Now, obviously, when I say brain, I include the spinal cord also. But the key thing is that it's not in the peripheral tissue. And then again, welcome to humanity. We are very susceptible to self-deception. So we need to realize that we will always, there's a saying that the biggest impediment to you reaching your goal is that you see a clear path to a lesser goal, right? So this path is so clear that the chances are that you'll just take that. The problem is that is a much lesser goal than the goal you want to have. So we need to really keep telling the patient that it's going to happen. You're going to see a difference. And one of the reasons medicines work is the expectation. Our cultural expectation is so high that we'll find the right combination to fix it, that there's a lot of that is placebo. So gradually we need to sort of shift that sort of giant cultural perception, because the price is just too high in many patients. And then on the good side, the positive neuroplasticity, people who become efficient in piano or language, all those are examples of positive neuroplasticity. So again, you can become efficient in becoming a self-soother. Now it might take time, so somebody else might have to soothe you, and when you soothe the person, you're toning down those networks that are just firing excessively. So a lot of the techniques for pain relief focus on altering the perception, how we experience what's happening on our skin. People have, this patient, she had a lot of neuropathic pain. So I would have her physically actually put her feet in cold water, and the pain would be less. But then I would also tell her to imagine that the feet are in cold water. Or even she likes snow, so she would imagine that she's sitting out and her feet are in the snow. And she experienced some of that effect too, of less experience of that pain. I've worked with a lot of other patients where they have used all kinds of imaginary techniques of feeling warmth or cold, and then you can actually change your own perception. If you have vivid imagination, you will actually feel that those hands or the feet are actually cold. Studies have shown that when you do functional magnetic resonance imaging and you give a placebo, those same networks are firing that fire when you're giving an opioid medication. We know from studies in war that sometimes the person is in severe pain and yet they go through whatever they have to go through. So what's happening to the pain? The brain is releasing so much of opioids that the pain experience is shut down, maybe because their life is in danger. So they have to run, or they have to, carry their broken hand. So, we have this endogenous opioid system that we can somehow trigger, and we need to just sort of become better at it. When I see a lot of my patients in pain, I feel that I'm happy just because I don't have pain. You don't have to have something good happen to you to be happy. You're just glad that you don't have so many problems that many of our patients are having. So, and in the elderly, there's a large group where they won't complain of pain for a variety of reasons. So, and then you have dementia where the way they would express pain is that they would talk less or move less. So it's noiseless. We've all heard, if somebody says they are in pain, there's a good chance that they are. And again, we have to really switch gears, not only from biomedical to sort of include psychological, like cognitive behavior therapy or behavioral, but also social components, because a lot of chronic pain, the volume in the brain goes up and down depending on which person comes into the room, how they interact with the person, what interpersonal relationships they have, how intensely negative the relationship is, or how positively soothing the relationship is. So we are highly responsive to environment. And last but not the least, in chronic pain, the big factor is the spiritual dimension. So again, the more we include that in our routine, again, we'll have much better results. We have the sensory component that we focus a lot, but the suffering component, we don't focus as much. And then obviously there is a whole separate sort of disability component. Each of us are in pain, our behavior will be very different. So, I told the patient that, she was worried that I'm giving her too many medicines, whether this was just opioids that she was on. And I was telling her that in chronic pain or persistent pain, more than one neurotransmitter is involved in 99.99% of cases. So there is actually a reason for rational polypharmacy, right? So low doses of 2 or 3 different medicines would be more useful. And then she was very upset that I put her on Cymbalta, because she said, I'm not depressed. So I told her that I'm giving it for pain management. And studies have shown that you can do a depression score, you can have no depression, and yet when you give pain medication over time, the pain is less. And that's because some of the antidepressants act on serotonin, norepinephrine, and these are involved in chronic pain. And then you'll hear again later on that there are different types of pain. So again, we sometimes try and treat one pain with opioids, and opioids are not very good at treating neuropathic pain. And again, in the long run, the risks just accumulate too much. So we need to realize what type of pain we are treating and whether we are matching the medications to that pain, besides matching sort of the interventions, the non-drug interventions on imagination and relaxation and sort of physical therapy and things like that to the kind of pain you're treating. Again, the problem with neuropathic pain is that generally pain is good. Obviously, if you didn't have pain, you would not withdraw from a painful event. But neuropathic pain, there is no protective function. It's just a misfiring of the brain. So it becomes very hard to try and see anything positive in that. And as I said, allodynia is when you have pain from, say, touch, something that's non-painful. And then hyperalgesia is that something that's painful, the person will experience even more pain. You see that in people who sometimes are on opioids chronically. So another reason to be wary. So, I've talked about this. A lot of my patients really, when they are in pain, I have a patient with chronic headache, and she struggles to wrap around. She has severe migraine, disabling migraine. She has a neurological component too, which is a whole separate story. She couldn't tolerate a lot of migraine medicine. She's still struggling after 2 years of suffering quite a bit, of trying to find meaning in this. And there's a whole, group of studies that show that, when you find meaning, then the suffering is not as much. Have you heard of Viktor Frankl? So he has said, that the man is not destroyed by suffering. Man is destroyed by suffering without meaning. So again, we need to, and I had another patient who really, when actually I didn't do all this work. The person's member of the clergy, the chaplain, talked to her because she would not talk to us about why she's not taking pain medicine. When in fact she was the exception to the rule, by the way, where I wanted to give her opioids and she didn't want to take it, and I just couldn't understand. And she was in severe pain. She recently had surgery, and the chaplain found out that she felt that this was a punishment to her from, years ago when, she had decided to have her child be adopted, and she just felt guilty for, can you imagine, like 40 years. So now she felt that, she's going to pay for it. She would rather pay while she's alive, And so a lot of spiritual work was done, and eventually she did agree to a small dose of opioids, and that was enough to really get her. It was still a struggle, but it was much better. And then, many times we focus on the patient and don't focus on the family members. I have so many patients where, when I focus on the family members, the person's pain is less, right? But the family members won't see me because nothing is wrong with them. So I schedule a visit with the patient, and I spend 5 minutes with the patient and 25 minutes with the family members. But that's okay, The bill goes in that person's name, and so we don't have time to go into the details, but there are very many misconceptions about pain in the older adults or dementia. People don't feel pain, and that's not true. So before I go on and on and on, let me just pause and see if you guys are digesting what I said. Anything that I'm saying is connecting with you. All this, you've known, been there, done that, tell me something new.
That's kind of a whole percentage, of like the somatics of the joint pain and visceral pain and neuropathic pain. What would you say is kind of the percentages as far as the whole pain map? That neuropathic pain, like 10%, 20%?
It's I would say higher than 30%. So, and a lot of people have double whammies. I haven't seen as many triple whammies where they have visceral pain, nociceptive pain and neuropathic pain. Nociceptive pain and neuropathic pain are very common, especially if you have spinal cord problems. Sometimes you have arthritis, but you have vascular disease in the brain. And vascular disease doesn't manifest as stroke. So you ask them, any strokes? No. You do a brain scan, and the whole brain is knocked out by ischemic vascular disease. That's a source of neuropathic pain. And you won't know until sometimes you do imaging.
As a physical therapist, I've spent a lot of time with people who have chronic pain, trying to convince them to do exercise and things. And you talked about in one of your earlier slides about separating the activity from the pain. I feel like I spend a lot of time trying to decrease their perceived threat of what the pain is. So how do you balance that, trying to remove the focus on the pain and yet trying to educate them about it at the same time?
Right. Well, it's training, so it takes time. And I tell them that, let's say that I give them concrete examples. So each time you walk, imagine that these, brain networks are now firing, and imagine that they are shutting down these pain networks. And imagine that, the drug that is trying to increase these opioids are increasing each time even you take a step.
Yeah.
And each time you say, all right, let me just stop and take a deep breath. Then, you're lowering the volume. And I give them examples and a lot of hand holding. And then they take a small step, you sort of blow it up like, wow, really? That was phenomenal. We're all,
We've all done that.
and then it works, but, have you guys heard of mirror neurons?
Yeah.
So what happens is that when we say, wow, even if they don't think it's wow and they think that we are like BSing, those same brain networks will fire anyway, that sort of hype up the wow, So, and then opposite is true too, if a family member is all angry, then those networks will fire, even though you're not angry, but the angry networks will fire, and before you know, you're also angry. So we need to harness that mirror neurons. The problem is that, we have so many other things that we can't spend as much time. But if you spend a little bit more time and, once you see the effect, then, your excitement will just go up.
How do you counter it when people believe that what you're saying it means you think it's all in their head, which they see as a negative thing?
Right.
You don't believe them, or you believe they're making it up, or something like that. How do you react?
Well, I tell them that, if I was in your place, I would also feel that way. So there's no question. The reality is that even though it's a disease, when you have chronic problems, a lot of what is happening is the miswiring in the brain. And once they know that you really care, I've seen that, they develop trust. And once you tell them that, this is not that somebody who has high blood pressure, I would not blame them for having high blood pressure, it was probably a gift from your father or mother, So, but that doesn't mean that, you don't exercise or, sort of cut down on the salt, things like that. And then they're able to, and I tell them that, and the brain, I tell them, will want to think it this way. Because remember, the brain wants to take the clear path, which is, there is one pill that's going to fix it. But that's not going to achieve the goal, which is that it takes hard work, and then the response is not going to be great, but it's going to be, decent. So I tell them your brain will want to reject anything that involves a lot of work. It's not because we are born lazy, it's because the brain doubts whether this investment is truly going to work out. It's our evolutionary brain, we are just 17,000 years into civilization, whereas for more than 1 million years we were in the jungle, so the brain focuses on survival, it doesn't focus on sort of higher things in life. Right, we'll move on. So we know these steps, and again, there'll be repetition of a lot of this, so I would urge you to read it on your own. Again, pain management goals, sometimes our goals are different from the patient's, and then expectations. A lot of this is expectations, the expectation is that the pain, really substantially decreases. I tell them, pain is a friend who's a pain, right? But, it's a friend, so once you've said that you're a friend, then when they come to your house, you just say, come here, just sit, So, they have to see this relationship. Now they have developed a relationship with this called chronic pain. And I tell them, give a name to this entity, whatever you're going to call it, And, we have so many things in our lives that we don't want, right? But guess what? We're stuck with it, right? And so, we have to just sort of see the whole relationship differently. you'll see these things, but the key thing is in dementia, people also, they are able to use this until the dementia has really progressed. So we need to continue to use them even in mild to moderate dementia patients. And then obviously in very advanced patients, you see behavior. The problem is any distress in advanced dementia will manifest as behaviors. So actually I would even make a case that when in doubt, you just give them a trial of, say, Tylenol. And there are studies to show that, in a small group, 20% the behaviors come down, which means that their agitation was related to pain. And you thought it was just dementia-related irritability or mood disorder, and that wasn't the case. And, everybody knows this, right? Fifth vital sign. So what is the sixth vital sign? Yeah?
Walking speed.
What's that?
Walking speed.
Walking speed. So each group of professionals will have their own six vital signs. So mine is delirium when I'm working in the inpatient setting, and depression when I'm working in the outpatient setting. Right. So this now in these things, the volume is really loose. So which means that you sort of just the volume can go up. So a small event in an interpersonal relationship. Somebody gave a phone call, and they were just angry that and then in 2 hours the pain has gone up, and sometimes they don't connect the event to the pain. So different pains have different sort of volume looseness. And then look at this study. It's like well, not this study, the next one. But again, attitude matters. Some people say pain is really totally incapacitated in my life, and a lot of other people say it's not too bad, and you have to convince them that you're not walking, you're not engaging in social interactions, you're not getting out of the house at all. So taking medicines in this case is better, not opioids, but other medicines is better than not even taking anything. So but there's one study that I have to share. But before that, so there's the whole concept of limbically augmented pain syndrome, and it just means that if you have, as I said, hypoperfusion, that is seen in a lot of people who have chronic diabetes, not chronic, who have long-standing diabetes, long-standing hypertension. You can assume they have hypoperfusion in the brain. Then, if they have arthritis or back pain or recent surgery, the brain has been sensitive. It's limbically augmented already. So it was like a subclinical neuropathic pain, and then you had a nociceptive injury, and then you have a whole big problem compared to somebody who doesn't have cerebrovascular disease or neurodegeneration. And then obviously, on average, 25% of whatever happens is genetic. That's good news and bad news. Good news is it's just 25%, thank goodness, right? Depending on family history. But 25% means that you can't get away from this, which means that it's not like we are going to be like that 80-year-old who is walking every day, doing all the puzzles, is independent, really, because our genes might be different, and we might have a different sort of life at the age of 80. So that's just reality. There's no getting away. But look at this. So, the researchers were told that we are assessing, a lot of things. One of them is, how painful is this sort of shock. And then the volunteers thought that the other person was intentionally trying to give them pain. They said this really hurts. And obviously, it was the same intensity of shock, right? But the pain experience was from 4 to like 9. All right. So what's happening is that when you feel that something is done intentionally, your experience of pain is very, very high. So So and this takes place in a lot of patients who have dementia. So they can't process everything. So when you're upset, they think that you're upset because of them. Or when you're trying to move them and they have arthritis and you didn't move them correctly and they had pain, they will assume that you're intentionally trying to bother them or something. Then their experience of pain is going to be much higher, and then you wonder what was that about, right? But there is that factor, so we have to tell them it's not this wasn't intentional, things like that. But it's just good to know. Sometimes the family members get all upset, even when 95% of the time it wasn't intentional. But then you know this. So obviously we know all these goals, but it changes with acute and chronic. Acute pain hit strong, hit hard. Very different when you're talking about chronic pain. And a lot of times chronic pain is because the acute pain was inadequately treated. So our focus is on persistence of chronic pain, but keep that in mind. So again, we have lots and lots of options, and there's a whole long list that one can use. I don't know how much of this is used routinely. Quite a bit. Any areas where it can go up, but for sort of systemic reasons or reimbursement reasons, it can. Any intervention, like does everybody get spiritual consults? Does everybody get one-to-one self-soothing person who's like a super soother? There's some who are and some others who are not, and then you would give them say Angela, just saying to me, 15 minutes 3 times a day. So part of the prescription. I'm serious. I'm serious. So anyway, we need to sort of do really more of this. Again, I'm preaching to the choir, so I'm not going to talk much on exercise, but stretching, strengthening. Neuropathic pain responds a lot to temperature, so muscle spasms. Simple things like positioning. And none of this I know. So that's why it's important to have a team, because a simple intervention by somebody who knows this would suddenly relieve the pain. Whereas, if they're with me, I'll say, "Oh, imagine more, really." And then art. What about art? That's something that let me bet it's not a part of routine practice, right? If I had one lesson, what would that be? I'm telling you. Now, this is not evidence-based, all right? It's one study. But there are some studies that you see. But the reason there's no evidence-based is because the money doesn't flow here. Nobody's going to get $1 billion grant to study this, whereas, you will get a grant to study a new drug and they'll spend $600 million, And even if it gets rejected, they'll try a different drug, So, to me, absence of evidence is not evidence of absence, really. Art is a way that you can really channel a lot of negative experiences, emotions, and again, I've seen people work wonders in terms of this. Again, how many of them we encourage them to express themselves, tell their stories, write it up, and studies have shown that this will reduce pain. So everybody, I would say, art. If that's a checklist, this is in the inpatient unit too. This person, the 83-year-old that I was treating, so she liked to do collage. So she had to find some magazines that she liked, and she would cut it and start doing that. And that, at least for those, and then I would say, I wanted to engage in art for 15 minutes 3 times a day. So she wasn't interested in writing, but she was interested in chatting. So I would tell the nurse that if the unit census is low, and I would want to just chat with her for 10, 15 minutes, but focused on certain things that she could express, and then the third thing, if I have to pick, the first thing is art, the second thing is expression. The third thing is laughter, we just don't, I would, if I say, then I would say no news, that's it, in the entire hospital. Obviously, some patients will go into withdrawal and you really immediately have to put on the news, right? Because they are so dependent on that information feed every single day for 5 hours. But to me, that's an exception. For the majority, there's just no benefit. Just watch as many funny shows as you can. And you'll see them, if you see your body changes, it's like, really? It's just amazing. And then you can, in the future, you have high tech. That's really, a lot of the CEOs love it, to have a patient who's sent to fMRI and then you provide like a $10,000 therapy, right? There you go. So again, you can create a virtual reality where the person really feels that they're in a very different place, and that can soothe their neuropathic pain or their arthritis pain. So, you can have visual reality goggles, and you can ask them to, increase or decrease their sort of coldness of that, thing that they are in. And then you will see all the brain networks firing very, very differently. And then you train them. Have you heard of neurofeedback? That's the same thing, you have a sort of your favorite music coming up each time you are in that relaxed state. And then if you're not, you don't hear the music, so you know that your brain state has changed. In the future, we'll have gadgets on our wrist which will tell us everything, including how relaxed we are, and how much calories we burned, and how much walking we did, and things like that. So it'll be a continuous feedback future. But studies have shown that a lot of us don't need any psychotherapy. The minute we get feedback, there's a good chance that we might change our behaviors. So a lot of our current ways, like your patients, when they do exercise and all, they say nothing has helped. But if they suddenly see that the brain waves are changing, some of the brain networks have come down, then they will see, okay, then maybe I need to keep persisting. So it can have a tremendous effect, so we don't have that at this point. So as the flame wanes, the patient feels better, And again, in the older adults, in terms of pharmacological interventions, what is more important is what not to use. And then that's just hard. And again, remember neuroplasticity. If a physician has had those two brain networks wired, and the patient says, I'm in pain, and if they have for the last, out of 200 visits, for 190 visits, they have prescribed the medicine. Those two networks are wired. If that person gets another patient, guaranteed there will be a prescription coming out. So sometimes I tell patients that you can go to the doctor, but don't say a word. If you have one word, it'll be I'm okay. Because if you have pain, you get pain medicine. If I'm just kidding. But sometimes you see the patient, I have a patient who's on anti-anxiety medicine, antidepressant medicine, mood stabilizer, pain medication. Really? And then I have a patient who's like 18 years old and have disc problems and now and they are already on sort of ADHD medicine too. So my goodness, if we keep going on, how are we going to rewire this person's brain? So there's a whole long list that we won't go into, but what we know, as I said, is what not to use. And a lot of my treatment involves cutting medicines down and helping people avoid or switch to safer medicine. Yeah. Keep going. And we don't have time, so I wanted you guys to see some other things. But in terms of those three objectives, one is neuroplasticity, one is the risks of opioids. And let's talk a little bit about the risks. So what have you seen? Or what are your thoughts on opioids? Is it similar to mine, or really on the extreme side of opioid?
What? I have a patient I just discharged recently where she was taking like 20 milligrams of oxycodone at a time, and still like saying that she had pain and wanted more medication. Was angry with her physician because he wouldn't prescribe more oxycodone, and you know, and she's the one who I was trying to decrease that threat level. Like, you're experiencing pain, but is it really hurting you? Like, you know, like it's not damaging anything. It's not, you know, it's there. Let's like focus on your life and what things you want to do.
Well, see, I'll use similar but slightly different wordings. Like, you know, pain is a signal that, you know, something is damaging. So I would tell them that actually it's a false alarm because the brain has been rewired. So things that are really not going to cause you damage. So I'm not saying that you're not experiencing severe pain, but it's not going to lead to anything really terrible. And again, in that case, in her case, maybe nothing you do would really help.
Yeah.
The problem is that a lot of physicians most of the physicians are nice people and want to help. The problem is that sort of wish sometimes overrides, because as I said, that's a clearer path, right? After all this, you just give it. It's much easier than saying sorry and taking all that brunt of anger, because when they go, you know, remember with the mirror neurons, all that anger is going to cause distress, and then it'll take some time to regroup, you know, let's say my mental state. So a lot of them just get what they want, but we need to just say that. And I would say that in that case, you would have helped 99% and you would damage one person because they really need a higher dose.
Yeah.
But at this point, since we don't have, you know, very sophisticated biomarkers, I would rather have that than sort of have a flip side where, you know, I'm harming many more patients than I'm helping.
So somebody like her, how long do you, like, you don't know her, like her whole case, but you know, somebody like that that's like medication seeking, outrageous, you know, 10 out of 10 pain, but flat, no affect change, no crying, no like, you know, she's not passing out or anything because she's in so much pain. When you're working with her, how long does it take for you to start getting some meaningful changes in her pain, perception of pain?
You know, I've had one patient who came for 2 years, and you know, and it took a very long time for her to engage in all this. And actually, a lot of times I thought maybe I should see her. And then when I would talk to my colleague, one colleague, he said that that's the easy way out. Because you don't want to, you know, he said that why would she come if she's not getting any benefit? You know?
Yeah.
So just stay the course, and you know, and even now I'm not sure whether, you know, I should have just gone ahead and prescribed. You know, we all have to cope with uncertainty. But you know, when my colleague said, you know, just stay the course, because of the same logic, you know, in 99% of cases, this approach will have more pluses than minuses. So there's a couple of handouts that I want to show. So let's do with breath awareness exercises. So I just, as I said, you know, if the person doesn't like it, I remove the meditation word, right, exercises, and present the exact same thing. And this patient, I did it in front of her, right? So she knew, and yet she didn't mind it. So, you know, I don't, you know, want to be dishonest, but I was trying to tell them. And these are something very simple. That the problem is that we're not engaging in these kinds of relaxing strategies enough. You know, if somebody does it for like 10 minutes a day, nothing is going to happen. So we have to really increase our intensity of engagement, and then you will see a difference. And so in my office, actually, I spend 1 or 2 minutes, and I would encourage you guys, put in a list of art and expressive humor. If I had to add a fourth one, I would say, and if nothing else will help you, you say, you know what, before we go for physical therapy or something, let's just sit for a minute and practice deep breathing. Let's anything else, right? Let's do this. And then when they do it correctly, you say, way to go. and then, or if you can do it for 2 minutes, even better, you know. So, and then I tell them that, you know, do it for 2-3 minutes every hour. Again, many times you don't see a physical difference, but if you do all kinds of sophisticated biomarkers, you will see that their stress hormone levels have gone down. You know, the brain waves have changed for like, you know, the next 10-15 minutes, you know. For 1 to 2 minutes of breath awareness exercises, the brain waves have changed for 10-15 minutes. You do it for like 20 minutes, they've changed for like 4 hours. Then again, it dies down, so you have to do it again. So you know, and then feel free to use this, you know. So the next one is NBSR. Let's try that. So again, you know, a lot of people like sort of concrete things, and so I tell them that what's your score on all these things, you know. And studies have shown that, you know, when they have a set score and you measure them, you don't have to do any counseling. You know, every time, you know, they come to me, they come with a score, I tell them, you know, what are the challenges and how we can increase the score. And in 2 minutes they leave, you know, I charge my $300 and both of us are happy, you know. So, you know, again, but a lot of this is telling them that, you know, how many times have you, you know, had, you know, touch? Studies have shown we are very sensory creatures. We just entered this world of hypercognitive world where, you know, information is like rules us, you know. But if you re-engage our senses, you in a positive way, then our brains will change. So, and now this gives us something concrete, like every day you can have a checklist. Some people don't like it, but many people do. So, and there is one more handout, which is pain control techniques.
What do I want to do?
Anyway, this it won't open. It's a PDF. Yeah, there you go. So this gives you more specifics. So again, read up, you know. So each technique has given a name, like altered focus or dissociation, you know. So splitting, mental anesthesia, and each of them, you know, there is some research to support it. So again, I would encourage you guys to read up about it. Remember neuroplasticity, so 99% of what I say is just going to evaporate. So unless you, so that's how our brains are. You know, new information is just not going to stick unless you revisit that and then put it in the context of the patient. So if nothing else, you just carry these. The best way to learn is to teach, right? So you just, all you have to do is carry these 10 sheets around. And you meet 10 patients, you just say, hand it over and say, I want you to tell me about this tomorrow. I want you to actually teach me about it. There you go. 2 minutes of relaxation, your blood pressure is better. 5 minutes of them telling you all these techniques, you learn something new. And you tell them which one you're going to use. Kind of better than that, right? And the last one is, this is great. If you can just go down a little. I don't know whether we'll be able to read some of the words. So each person has been asked this, you know, give their story about living with chronic pain. And let's go down a little more. I want to quote, there you go. Yes, there you go. Living with pain is a contradiction in terms. Why? If you're constantly in pain, you don't have a life. So, you know, a lot of these things give us, you know, the importance of our work. You know, when we engage in all this, you know, a lot of these are seeds that you're sowing, so you know, you just don't know how they will blossom later on. There's one or two more statements I want to read. There you go. I think it is always wise to pace myself and approach different activities with a little bit more care. It takes a lot longer for me to do things than when I was a lot younger, and I try not to let the pain affect me. So many times, instead of my telling them, I you know, read these quotes, and I try and find out whether they can connect to this person. And again, another thing, we have gone to 4 things, right? So the 5th thing, okay, let's go with art, expressive writing, humor, then these techniques, and then 5th would be group therapy, where, you know, if they know that they're not suffering alone, if they know that the other person has tried it, and it has found useful, they will buy into that more than you and I, because honestly, we are not in their shoes. We don't know how the world looks. So, you know, so that these are the kinds of approaches that will really have a radical change in our goals. Is, you know, relieve pain. It's nothing more important than our work in relieving pain. So, thank you very much.
Do you have copies, or are they? Is this information in here on the meditation, the breathing awareness? I didn't see it. So. He provided us with the information this evening, and I'll have that information available. Because I can see us using that a lot, incorporating it with our education.
It'll cost you, but you can have all of it. So you guys know any jokes? Rehab jokes?
I have a question. With our length of stay, not a joke, sorry. Our lengths of stay are usually between 9 and 14 days. And with neuroplasticity, that takes quite a long time to retrain. What are some...
Yes or no? You know, it depends on, you know, like we are very emotional creatures, whether we like it or not. So if we somehow know how to raise the emotional intensity, then, you know, at least in, I would say, 20%, you will see that you have really changed their brain for long term, you know. So,
what are some of the the top two ones that you see the quickest acceptance and response from?
top two sort of approaches.
Approaches, yes.
Well, you know, to me, if I had to pick two, which you guys probably already would pick, is physical activity. That's different from exercise, right? So, and I actually tell them that each time you move the hand, it's like these things are happening in the brain. So they have to actually imagine that's happening. Each time they take a step, you know, all these changes are happening in the brain. And then breath awareness, meditation. Because again, you know, the way when we have a cut, you know, sometimes we don't do anything and it heals, right? Same thing. The brain will actually heal itself in many areas if you just back off. You know, stop sort of beating yourself down or stop focusing on negative. So when you're doing breath awareness, it's hard to focus on your breath and think negatively over, you know, what a miserable day I had, you know, this thing is never going to go away. So at least then that gap, you know, the brain got a 5-minute gap where it could do some healing of its own. And I'm telling you, even if it doesn't help them, you will benefit from it. Yeah, you'll be more relaxed at the end of the day. You're more relaxed than in the morning, you know, because you did it 10 times. All right, so how do two psychiatrists greet each other? You look fine, how am I? One more. So, who's the neurotic person? Raise your hand. Okay, the other two choices are even worse. The neurotic person is the person who builds castles in the air. You guys heard of this? No, keep going. Oh, who's the psychotic person? He lives in those castles. And who's a psychiatrist? All collect rent. Thank you very much.
Thank you.